Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon. I'm a physician scientist at the University of Colorado, and today we're talking about radiation. And to answer those questions, we'll be talking with Bill Thach and Tim Waxweiler. So maybe you both can take a second and introduce yourself. We'll kick it off with Bill.
Hi, everyone. My name is Bill Thach. I am a stage 4 neuroendocrine carcinoma patient of the rectum. I've received 25 rounds of external beam radiation at the initial diagnosis, and then I also received 4 rounds of PRRT, which is a radiopharmaceutical.
Hi, everybody. My name is Tim Waxweiler. I'm an academic radiation oncologist. I'm an associate professor here at Colorado, University of Colorado with Dr. Concannon. And I also serve as our residency program director, so I help with our trainees, kind of overseeing their education as they go through training in radiation oncology.
Great. Well, now you'll be able to educate us. And it's funny, I'm a medical oncologist, so I treat patients with like chemotherapies and things like that. But we don't get as much actually education in radiation oncology as people would think. So it's great. I get to punt a lot of my questions to you, but I bet even here, myself or my colleagues would definitely learn something.
Yeah, we're often a black box, I would say, even in medical training. I think out of a class of maybe like 140 medical students, I was the only one that ended up going to the specialty. And so you do hear that a lot, that we're such a niche, kind of specialized group that often other practices are not experienced or exposed to what we do with our kind of niche of oncology, I would say.
Yeah, even for med oncs, and I think it's true for surgical oncologists, we don't have to go down and rotate with you all. Like, it's not part of our formal education to learn radio. I did in med school, but after that, I didn't go down in residency. I didn't go down in fellowship. So, so for those who are asking questions about radiation to other providers who are not a radiation oncologist, it's a black box to everybody. So hopefully we can shed some light on it here. And maybe, the first question to kick us off here is to Tim. How would you describe what radiation is and how it's used to treat cancer?
Yeah, so there's a number of tools and modalities to deliver radiation. But at the end of the day, it comes down to it's primarily energy in the form of waves or particles, but you're using it in a directed manner to target either a cancer or some type of condition. And there are a number of non-cancerous conditions that we treat as well. But ultimately, you're using it to kill cancer cells and help try to either cure a patient or improve or palliate some type of symptom that they might be having. And so often patients come for a treatment and they're receiving primarily the most common modality we use is what we call photon radiation. So it's very custom plans delivering essentially X-rays that are high energy X-rays that are invisible. A patient doesn't see, feel, or really hear it as they're receiving the treatment, but we're kind of customizing them and individualizing them to a given patient's condition.
Yeah, and I want to get into like the different types because a lot of patients come to me and everyone wants proton. They've read about proton and other stuff will come out and they'll bring it up to me and I'm like, there's like one center in the world that does whatever physics thing is happening. So we should get into a little bit of that later. But Bill, I'm curious to hear when you first heard that you were going to receive radiation, what was your perception of what that would look like and what that experience would be like?
Probably my first question was probably, am I going to be radioactive? That's probably the most common question that people have when they're going into radiation. But I later saw that it was basically not that wasn't really the case, just because it's basically a focus amount of energy going to that one specific site. So after I got that information, I just tried to do everything possible in terms of mitigation of side effects. Where because it was in the rectal area, I did a sitz bath every time I did a session of radiation, and then I pretty much wore a diaper for the whole time, just because it was one of those things where I was also getting capecitabine on top of the radiation, so it was hard to know if I was getting the side effect from the radiation or the chemotherapy. But because of the area that was radiated, it was common to have diarrhea as well. So that was why I wore a diaper.
Yeah, and I think you're getting to some of the side effects of radiation. We're mentioning that radiation is a focus of energy that goes into a particular tissue type, but you got those symptoms probably because it hit the cancer and then some of the tissue around the cancer. We always need some sort of margin. So Tim, maybe you can explain a little bit, like, how does your team figure that out? How do you identify exactly where to focus your energy beams? Is there a lot of margin? How do you spare healthy tissue? What's the process?
Yeah, I think that's probably the area we've made the most progress on technologically with radiation delivery over the decades. And prior to my training decades ago, my understanding was you kind of didn't know where to treat. And so you just treated a broad front to back area of, say, the pelvis in Bill's case, and there might be a beam coming from the front and a beam coming from the back. And you would truly give an overlapping dose to all the intestines and bladder in that area. And we've essentially realized that all the radiation side effects are tied to the tissues you're overlapping with the treatment that are often going to be nearby the target. And so usually stuff that's near wherever a given cancer might lie. And over many, many years, I think we've gotten better both at imaging, so doing CAT scans, MRIs, PET scans, various different tools to really see first what is the target. And then in turn, the process to actually customize the delivery of the treatment has become much more refined. And we now have very thorough guidelines and atlases essentially outlining, for Bill's case, for example, where do you target, what part of the rectum, what other areas at risk for cancer, such as lymph nodes, might you include. And so we've really individualized the actual target outlining, and then the machines themselves have gotten better to be able to deliver from a complex set of shapes and angles, a unique plan where we can really push and pull the radiation dose. Almost, some people say it's almost like adult coloring in a way, which is we're painting the radiation to the areas we want it to go, but we're steering it away from the tissues we might want to avoid and try to minimize those side effects. So it's something that has become a lot more tolerable, yet still does have side effects that we have to help manage.
Well, and as you're mentioning that, could you go into a little bit of how that's actually physically done? Like, how are you mapping out where it goes? And what I'm getting at here is the field of really dosimetry, because I've seen these. I mean, they're actually pretty diagrams. You have the different colors of how much dose is going into what area that's around the tumor, but you have to do this in 3 dimensions, which is tough to do. We see all the CAT scans in a 2-dimensional image when we're showing them to patients, but you have to think in 3 dimensions. How is that like physically done? Who's doing that?
Yeah, it's a team effort for sure. And so there are people actually called dosimetrists, and they go to specialized schooling just to plan radiation treatments. We also are collaborating and overseeing that planning process with them. And then we also have physicists. I think that's one of the kind of geeky joys of our field is for most every one physician we have in the department, we probably have another physicist that we work with as well, very closely. And so kind of, I would say front to back of the planning, it's we start with taking a bunch of specialized scans and doing kind of a mapping session we call a simulation that I imagine Bill may recall going through. And that's just to get the initial positioning set up that we would imagine our patient being in for each day of treatment, something that's consistent and reproducible. And then there's this process we call contouring, and basically that's outside of clinic. The physician will sit down and go slice by slice through all those scans. And so we're drawing 2D kind of outlines of the target areas, but going slice by slice to ultimately create that 3-dimensional target. And then in addition to drawing the target, we always want to draw in what we want to avoid. So we might draw in the rectum, the small bowel, the large bowel, the bladder, in the case of something being treated in the pelvis. And then we have kind of directives to our team of how much dose might we allow to a given organ, how much dose do we want to deliver to these target areas. And sometimes it's not just a single one-dimensional dose. It might be we want to give the visible cancer a really high dose, but then the at-risk lymph nodes a slightly lower dose. And then the dosimetrist ultimately is working on, with a very complex planning algorithm, they're working on how do they arrange different angles of beams and different shapes of those beams to ultimately get the dose that we want to have. And the analogy I kind of think of is we play off of two main tools to get that dose painted, which is the angle of beams. So if you imagine somebody on a stage with spotlights, if you had just one light shining from the side, that if that's a radiation beam, all the radiation is going to just pass kind of through that angle. But if you take another beam and you bring it, say, from a 90-degree angle, then the dose where the two lights overlap, that's going to be where you start to build it up. And in a modern sense now, we deliver the treatments with what we call arcs. So they'll 360 degrees rotate around a patient. Sometimes we do a more limited degrees. But ultimately, it's that intersection of where all the beams are angled where the radiation dose builds up. So we might have a fraction of the actual treatment coming through one given angle, and that helps us spare a nearby organ. And then the second thing is in the head of a radiation machine, there's something called a multi-leaf collimator. And essentially it's this array of, I believe they're about 6 centimeters deep pieces of lead, but they're about 2.5 to 5 millimeters wide. And each of these is on a paired independent set of motors, and they can create basically a really complex shape of the radiation beam as it's rotating around the patient. So it's a combination of shaping the beam and then bringing in a bunch of different angles that allows us to kind of paint it in that regard. It's also somewhat hard to articulate, but very easy to see in a visual. That it's ultimately playing off those two things to get the overlap of where we want to send the radiation.
And Bill, when you were going through this process, did you have a sense of what was going on behind the scenes?
Not really. All I knew was that they were basically focusing on that one specific area, and I had to do a tattoo of where they're gonna focus that beam on. And then there's also a cast made where they would basically put me in that position, and they would have me hold perfectly still for 10 minutes. And the sessions were very fast. That's the thing I did like, where the only annoyance was I had to come 5 days a week for 5 weeks. I've always been, I didn't bother to ask questions just because I just got to do this. But one of my questions was like, well, why does it have to be continuous and that often? I was wondering if it was even possible to even break that up a little bit more, just because taking off from work for 5 days a week, it's kind of hard.
Yeah, it's something I think there's a number of different factors that come into play. There are some tumors where we can treat in a single session, especially like areas in the brain, for example, where we can have a really tight focused beam and just treat a tumor. But ultimately, we also recognize that the way radiation kills tumors is it damages their DNA. So it's damaging kind of their blueprint for the cells to divide and grow into multiple more cells. And that also happens that we damage the DNA of the healthy tissues. And so breaking it up, it actually gives time for the healthy tissues to more repair those effects. And so going slowly in a general kind of theme tends to be much more tolerable and safer for organs in the longer run. There's also some belief in certain tumors where if we take too long of a break and do it kind of over phases, then potentially the risk is that the cancer grows back and we kind of miss our window to finish off what cancer cells might remain during a given course. So there's a couple different principles there, but by far that's the most frustrating and most annoying piece of what we do. And it's a major challenge, especially for patients that don't live in a city or an area where they have access to a cancer center, to either have to move or travel for weeks on end, it's very difficult.
Bill, what was it like going through the simulation process and having that cast made? Can you speak to that element of this?
For me, it was more like, oh, this is really interesting because it's something that I never would have thought I would be doing. But at the same time, it was a whole new world just because, okay, you have this monster of a machine that basically spins around you with an arm. And then you're like, you get scared because there's a little laser where you try not to look at it. It was like, what if it hits my eye and stuff? But it's one of those things where it's like a sci-fi movie where um I feel grateful that I am able to even receive this type of treatment, but at the same time it's like there's also a hopeful factor where it's like I hope this works just because with my type of cancer is like it's constantly growing, so and every treatment eventually fails, so I was just basically going through the process and just hoping, having the hope that it kept me stable enough to move on to the next treatment.
As those beams were going, like what is can you see them? Do you feel them? Or do you just see the arm moving around?
So that was the thing is like, because I remember I would see patients that would be waiting in the waiting room, and if they're a head and neck cancer patient, it's obvious. I was like, it's pretty gnarly when you see the redness all around their neck. But for me, I didn't really see. Well, I couldn't really see it either, just because it was my rectum, so I couldn't really see back there. But it didn't really feel like anything. I would say it's a progressive thing that you feel over time, where the first week I didn't really feel anything, but then after the first week I started progressively getting a little bit more tired with the fatigue. I started seeing a little bit more episodes with the diarrhea, but at the same time I wasn't sure if that was the combination of it was from the radiation or it was from the chemotherapy. But a lot of it I would say was fairly manageable.
Did you find, from what you were told ahead of treatment, did you find the treatments more anticlimactic and easier than you had anticipated, or kind of about what you had expected, or more? I'm curious your perspective as you went from the beginning to not having.
I would say for me it was easier, just because I'm also the type that thinks worst case scenario every time. So when that doesn't happen, it actually is a sigh of relief for me. At the same time, I tend to not really over stress things, where I'm the type that I'll deal with it when it comes my way. And I've always had a pretty good, strong mental state where I'm just going to go through this and move forward. But that's not the case for everybody. So I'm a fairly stoic person where I don't really try to let things get to me.
And Tim, one question that's come up to me with patients in the clinic, and something I've wondered, before going into medical oncology, is why can't you just radiate everything? Like if someone has disease that's spread to a bunch of different areas, why not just radiate all those areas?
Yeah, well, traditionally it would be that if you're treating the whole body with radiation, the types of doses that we use to treat tumors will ultimately be fatal. And that's from an understanding that you're giving too much radiation to things like bone marrow and affecting people's blood counts, so they're at risk for infections, but also too much dose to the gastrointestinal tract, and you can cause significant symptoms with diarrhea, nausea, vomiting, and ultimately dehydration. But it's something that, as the ability to deliver radiation more focally has gotten better and better, you've probably seen that there's this kind of group of patients we have with metastatic cancer where there's now kind of an in-between gray zone where we might actually try to radiate all their cancer, even in a setting of metastatic cancer. And so right now, if somebody has, say, one or two areas, say something in the liver or the lung, and no other active cancer, we might go after that with radiation if it's not something to remove surgically. And so that is one of the questions I think people are asking now is how much can you go after, and how many spots is too many spots to treat with a local therapy like radiation?
Yeah, it's been interesting as I have gone through training, and our training lasts kind of a while. So in the beginning of my training, it was kind of at least where I trained, it was really uncommon to radiate areas for individuals who had metastatic disease. I think the toxicity of the radiation was higher, and then the stuff that we could do to control the tumor you can't see, because usually there's kind of like seeds in soil, there's seeds of cancer elsewhere. Um, the ability to control those wasn't so great. So you'd radiate something, but other things are growing at the same time, and the whack-a-mole just gets out of hand. And it's interesting now that, we're practicing seeing patients and you're going through this process more. It's a lot more reasonable to do that now than it was back in the day, depending on what type of cancer someone has.
Certainly, yeah. And it's also interesting because I guess traditionally it was very binary. Somebody either had an early stage cancer that we could cure, and the goal was cure, and you used either surgery or radiation. Or if they had metastatic cancer, we said it was incurable and really reserved radiation only to try to palliate symptoms. And now there's in between state, something we call oligometastatic disease, just a few areas that have metastasized. That window to be aggressive has really broadened. And yet at the same time, we're also seeing a lot of heterogeneity there, that there are certain cancers like lung cancer where I think we've had a really good success and track record of helping patients live longer with that strategy. And there can be some other cancers, certain types of breast cancer potentially, that we're not seeing that same benefit. And so I think one of the bigger questions for us now is not just improving technologically how we do radiation, but also selection and criteria for who really is going to get the most benefit from these tools.
Well, and what a great segue into Bill. I mean, you've had radiation many, many times. What are usually the conversations around how effective it's going to be or why use it for your tumors?
The explanation for me initially was to basically just get it in under control. Just because after the first set of chemotherapy drugs, which was carboplatin and etoposide, a platinum-based therapy, we just needed to just get it under control where it allowed me to have the chance to have surgery, because at the time surgery was not an option. I forgot that I also received additional radiation during my surgery, just because I remember there was a radiation oncologist after my surgery where they said they were going to have a radiation oncologist do radiation to get the margins, just because we did do a pelvic exenteration where we removed my prostate, rectum, seminal vesicles, parts of my liver, and my bladder. So they just wanted to ensure that they got everything, but at the same time have a little safety net around that as well.
Well, and these are all, different types of radiation. Tim, maybe this is a good time to get into, from your perspective.
I guess the question is, was the radiation I got during the surgery the same as the one I got initially?
Yeah, probably not. I would say the end mechanisms and goal are similar, but just very broadly speaking, there's the most common type of radiation probably used in cancer care called external beam radiation. And that is the one that does not make you radioactive. And it's coming in for those daily treatments and having a custom plan that delivers this beam, usually of X-rays or photons, but also sometimes other things like proton or heavier particle beams that can target the tumor. But even with those advanced techniques, you're still passing that beam through healthy tissue, both on the entry and the exit. And so the other major type of radiation that's used is something called brachytherapy. And in general, the idea there is using a radioactive source and directly placing it in the area you want to target. And so that almost always will involve some type of applicator, a procedure, or a surgery to get access to the area that you want to treat. And in those cases, there's variations of options where you can have a very high dose rate material that delivers a lot of radiation all in a short period of time of a procedure, and then you remove that source later. Alternatively, there's something that delivers this very, very slow, what we call low dose rate radiation, and typically that involves using a permanent implant of something that's radioactive. And that's commonly done in prostate cancer, for example, where they might put down radioactive seeds inside a prostate, and those ultimately are there forever. And those patients are actually somewhat radioactive, and there's specific precautions we take in those regards. So yours, I believe, was probably something called like a high dose rate treatment, where they may have laid down something for a short period of time to try to deliver that radiation. And if that was also taking into account the fact, Bill, that you had the external radiation, we realized by putting in a direct source, you can deliver much higher doses to a tumor. And what we consider to be the dose fall off to the healthy organs, you can often get much more sparing. And so that can sometimes be a nice pairing with somebody who's had external radiation if you're not trying to push beyond and hopefully stay safe with the limits of what the organs can tolerate.
One question I've heard before, particularly for radioactive sources that get planted in the body, how do those not cause more cancer than they cure if they're attacking DNA and DNA mutations and issues? What causes cancer a lot of times in the first place?
Yeah, it's definitely always a question that comes up for our patients with any type of radiation is how likely is this going to be causing a new tumor or a cancer? And that is a real risk, especially for younger patients, pediatric patients that we may see. It's something that if there's probably a threshold where if you give too much radiation, or I should say cross that threshold, you're probably killing cells rather than creating a cascade of mutations or kind of events that might predispose them to later on becoming a cancer. So sometimes people believe where people see radiation-induced tumors or cancers, it can be on the fringes or these lower dose regions that get enough radiation to cause some abnormality or some initiating event that may years later lead to a cancer, but not too much to the point that you actually kill the cell and it never has a chance to turn into a cancer.
And along those lines, we have these patients who have a tumor, it gets radiated, and then we have this question, can we radiate it again? What are the downsides or risks of re-radiating an area that's already been radiated?
Yeah, that gets back to, we think that most healthy tissues probably remember the effects of radiation, and that when you come back and do more radiation, you've kind of used up some of the tolerance at that point. And there certainly is recovery and repair. And so the longer the interval between two courses of radiation treatment, usually the more we feel we can safely deliver a second time around. But even years later, if somebody's had radiation to a given region, we acknowledge that the risk of further radiation to cause injury to those healthy tissues is going to be increased. With that said, I also think probably our field as a whole, we're often very, very cautious with a primary mentality of do no harm. And we prefer to keep our risk for patients to have any type of serious injury to an organ as low as possible. And sometimes when a cancer comes back a second time, then we may talk with a patient and have a shared decision. Are we willing to take on more risk than we were the first time around? And so it's often something that it's very individualized, those decisions and those discussions. And as you know, Kyle, that it's something we explore all the alternatives. What's the role here for somebody to get surgery, or what type of drug therapies might we offer? But that ultimately it can be done, that we give a second round of radiation and it can be safe. But the stakes are somewhat higher at that point.
And do you have maybe a specific example in mind, or some sort of example where repeat radiation causes a potential harm? Like, when we hear potential harm, what should patients be thinking? Like, what is that harm tangentially or tangibly rather?
Yeah, it can range to any type of injury to an organ or a tissue. Usually, though, I think most of us in our minds, we're weighing potential things that can be life-threatening if we cause an injury. And one of those can sometimes be bleeding. And that if we give too much cumulative radiation to a blood vessel, such as a carotid artery in a patient with a recurrent head and neck cancer, or too much radiation to some bowel, a bowel could potentially perforate and either bleed, or somebody can get an infection from that if stool goes into the rest of the abdomen and pelvis. And so it is something, unfortunately, that all of us in our careers probably do have individual patients that have those serious consequences. And it's also an interesting concept, just thinking about this, that the feedback that we get is it's a very kind of time lag situation where we give radiation and we don't always know what the consequences are. It could be years later or months later that somebody has a consequence. And hopefully we're finding that out from our colleagues or from our patients. But there probably are a lot of things we are not aware of that patients may have some consequence, and collectively our team and our patients, we might not connect all the dots to say, oh, it might have been the radiation several years ago. On the flip side, sometimes there are issues that our patients experience that may not have anything to do with radiation, but probably because it's such a poorly understood treatment, radiation sometimes can be kind of the blame of an issue as well. So it goes both ways, but it's very complex, and it's hard even for us sometimes to really know, is this from the radiation? Even something like Bill was just describing, diarrhea, we recognize chemo can cause that, but definitely radiation probably was a major factor in causing that for you, Bill. So it's often hard when there's such a lag of timing for late effects to really tie them in cleanly, versus I think our surgical colleagues are often going to know pretty quickly if there's some type of complication from, say, a surgery procedure.
Well, and Bill, what have some of the conversations been with you around potential risks, benefits, and how have you navigated that?
With the external beam, I knew, just because it was so close to my prostate and my bladder, being impotent was basically a risk. And that's a very hard conversation to have with someone that's as young as me doing that. I eventually did become impotent, so that's the unfortunate part of things. But the surgery automatically did that as well. So it was basically going to happen regardless. The main side effects that I was told was basically you're going to be tired, you're probably going to have diarrhea, and you probably have low counts. But aside from that, that's basically it. It wasn't until I started going the radiopharmaceutical route where there's a little bit more side effects and risk profiles that had to be brought up, where I was going to be radioactive just because it was a concentrated source of radiation that's flowing through my body. But then at the same time, they did tell me that it was dispelled through the kidney. So I drank as much water as I could, and I just got to moving where if I could basically drain everything out as fast as I could mitigate the side effects a bit more, where I know a lot of patients don't do that, and they can end up in the hospital from adverse effects.
Bill, can you tell us a bit about the side effects you had with the radiopharmaceutical therapy?
So the very first dose I had, I actually really underestimated the Lutathera, where the first dose I had, I didn't really pay mind to how much fluids I was consuming and anything else, but I was literally stuck to the toilet, just puking my brains out.
Well, and Bill, can you explain to the listeners what Lutathera is, what this class of medicine is?
So Lutathera, also known as PRRT, is a radiopharmaceutical that is infused in your body for about 6 hours. It binds to the you have to get a dotate scan to have positive somatostatin receptors, and I did have that. So it binds to that receptor and it releases the controlled dose of radiation, and it is not harmful to healthy tissue. Did I get that right, Doc Tim?
Yeah, that's exactly right. The idea is kind of using a smart drug where you combine a radioactive molecule to a molecule that will go seek out the cancer in the body. And so that is sort of a third overall version of radiation is an infusion and coming for, I don't know if you came every few weeks for those treatments over a period of a number of cycles, but the idea being, again, to deliver the radiation directly to where the tumor sits in the body. The challenge with that is that those particles or molecules, they ultimately still go to other parts of the body and other organs and can still have side effects where they end up.
Mm-hmm. And then the frequency was roughly every 8 weeks. I would say the most interesting thing was after the infusion, I had something called a SPECT scan, and that was another machine where there was an arm that was basically going around my body, and it was basically just scanning like a CT scan. And I with the positive of that was I knew the results of the effectiveness of the drug literally within a week, which was really nice. But I was also just thinking in my head as I am getting a lot of radiation. So, and on top of that, I'll be starting my 5th clinical trial, and I get scans every 6 weeks. So I just have such a large amount of radiation that has been brought upon my body that I'm just guessing when I'm going to have a secondary cancer.
Yeah, Tim, can you speak to that? The risk of the cumulative radiation from different sources of radiation?
Yeah, I think it's something, of course, we're still always studying because as we get newer and newer therapies, then we need time for follow-up. I would say that usually there's a theme with when radiation causes a cancer, that it often probably will take years, if not decades, to develop. And then it also has to do with the region of the body. And so things like Lutathera, it's tagged with the radioactive molecule. It's something that has a very, very limited depth for how far the radiation travels. And so its intent is when you tag it to a molecule that then seeks out cancer cells, that you're trying to limit exposure of radiation to healthy parts of the body to avoid that, not just the risk of secondary cancer, but side effects in general. It's also something a diagnostic CT scan. It's usually orders of magnitude lower in terms of radiation exposure than the therapeutic radiation, whether that's through the infusions or through the external beam or through the brachytherapy. And so often it's a very real concern. We really do realize diagnostic scans over a population do probably lead to secondary tumors. At the same time, usually for our patients that we're working with, the radiation is both being directed carefully, and the primary risk ultimately is not treating an active cancer that we're dealing with presently. So we often will accept that there is that small risk of a radiation-induced tumor. And it's hard because in the vast majority of patients, they'll never develop a secondary tumor. And so it's, in one sense, we try not to worry about it, but we also try not to be flippant or ignore it, because if we treat enough patients and patients live years on end, then we do see patients that develop these tumors, and they sometimes can be very consequential and as serious or more serious than an original cancer. Overall, I sense, Bill, that your treatments have been very justified and very safe and judicious in terms of the recommendations you've received, that I would have a very, very low concern about that whenever you go for a scan in the future. Yet it's hard because it's not a 0% risk.
Yeah, but I also understand that it's the gold standard of showing that if my treatment is also working. So
Yeah.
there's a pro and con to it. So I don't really pay too much attention to it, just because it's information that I need to tell me that if a drug is effective or if I have to move to the very next course.
Tim, can you speak a little bit? We're talking about radiopharmaceuticals. Can you describe a little bit more about that class, and do you use them? In what circumstances are they used? Should people consider these? What do you think?
Yeah, I think it's something, it's maybe one of the most growing domains of radiation therapy, and it's an interesting one because you may see a radiation oncologist like ourselves to discuss and have those treatments given, but there's also another group of specialists in nuclear medicine radiology that can, like for example, here at CU, they oversee those therapies for our patients. And I think it's on all of us on the oncology side and the radiology side to understand these therapies and when a patient may benefit for them. And somewhat like Bill was describing, usually one of the first steps is first figuring out, do we have a cancer or a tumor that will take up a specific therapy that we have available? And if the cancer itself doesn't have a receptor to take up the radiopharmaceutical, then probably giving that therapy is not going to be that beneficial. But we're seeing these offered in more and more different domains of cancers. And so Lutathera, as Bill described, is one that uses this dotatate molecule that looks for a specific receptor on neuroendocrine cancers, as well as it happens to also be something meningiomas express. And another common area is in prostate cancer, that we're seeing patients that develop metastatic prostate cancer in their bones. There are now therapies that can be given and kind of directly deliver the radiation to those locations. So it's something that's almost kind of like a hybrid version of giving the drug therapies that you all give, Kyle, to, like in terms of smarter systemic therapies, and then combining that with the damaging effects of the radiation, but using it in a very kind of biologically specific or smart mechanism. But it's a very growing field, and I think we have a lot of progress to make there still.
When you mentioned that the radiation that these things emit doesn't go terribly far, can you elaborate on that a little bit? Like, what is actually on the molecule? Like, what's going on down there?
Yeah, so typically it is a radioactive molecule that kind of will just naturally decay or give off radioactive particles. And they can emit, the two most common kinds are something called alpha and beta particles that can be emitted. And they have slightly different, what we consider dosimetric principles for them. But that those particles that come off, they can only travel so far, and some of them can be stopped even by like a thin sheet of paper, for example, so that they may interact with whatever they first hit or travel a short depth depending on the type of particle. So the advantage of that is if something were, say, going to a tumor in the bone, most of those would not have the activity of like an X-ray or photon to go travel all the way through a cross-section of the body at that level. It's kind of the natural principle of the particle and the way the radioactivity of it, the way it gives off some type of damaging particle, that it only goes so far in a very near location to where it's delivered.
And a lot of times, one of the principles of radiation in my mind is that if something is radioactive, it's radioactive for a while. Do these things like break down quickly, or are they there forever now?
They can have a range of what we call half-lives. So some are relatively quick, some are relatively long, and it just kind of depends. And so often I think people are looking for ideal certain types of particles with certain principles for different situations, and then also wanting to pair that with the kind of finding the right receptor, or sorry, not receptor, but molecule that will target a receptor, so that it will go to the right location as well.
Bill, I'm curious, in your experience in the patient communities, are you hearing a lot about people trying to obtain a certain type of radiation over a different type of radiation? For example, the rumblings I hear are always like, get protons, always for everything, we want protons. Do you hear that kind of stuff?
I've heard from some people about Proton where they always recommend me to Proton, but I know that Proton is barely starting to make in ways where they're starting to go towards solid tumors, where before I think it was only used for brain cancers, right, Tim?
It ranges. I think there's always studies going on for all sorts of different diseases and cancers to see if there's a role where protons may be more sparing, so that they may have fewer, especially late, side effects for patients. And they're on paper, the physics of protons, they're definitely very eloquent with this idea that a beam comes in and then it has a certain depth where it basically deposits most of the energy, and that there's not much on the exit side of things. And in particular, probably where it's most proven and has the biggest role is in pediatric patients, getting back to our discussion about causing tumors, is if you can limit the kind of wash of lower doses of radiation across the body to other organs or non-target areas, then ideally you're also limiting those risks of second malignancies developing in the future for a young child, for example, who may have also a pretty favorable prognosis for a cure of their cancer. And then in turn, you're also hoping to limit long-term effects on their organs that they will need for decades ahead of life. And so there are certainly some advantages there. It becomes, I think, a lot more nuanced and probably controversial when you start to get into adult cancers, where there are clearly some advantages of protons, but there may be also some trade-offs. And I think, admittedly, I'm not a proton expert. We don't presently have protons in the state of Colorado, but from my general understanding, sometimes what you can also see is what is in the target with protons can be damaged more. So you might be sparing what's out of the target, but if part of the target includes a healthy organ, you might actually have a potential risk or uncertainty about how much radiation you're delivering to that area, where you could in turn still cause an injury. So it's something I think people are constantly, in a good way, trying to study through randomized studies where half the patients may do the traditional photon radiation, half may do the proton radiation. And it gets even more nuanced and complex because also there's lots of different, so to speak, paintbrushes and tools and styles to deliver these same, even though it's just protons and photons, there's plenty of different ways to administer them. And so I think often, personally, when I think about seeking radiation treatment, it's going back to the team piece of it. It's such a team sport with someone you're planning it with, the physicist, and the collective group that in my mind, it's often the collective group and the team and their experience that really drives outcomes for patients. Yet I hope we will get more answers in the years ahead about the role for protons in certain situations.
Mm-hmm. I also feel that when people bring up proton, they don't understand that there's not a lot of centers in the nation that have proton. I was able to tour a Nova in the Virginia Fairfax area, and I was kind of blown away on how large of a setup that was and the amount of money and investment that it required for a hospital to even have that machine. So I feel that it's just a good marketing push for a hospital to say we have proton and everybody's going to want to come to your hospital.
Yeah, I think there's definitely some of that. And yet also, I do think there are scenarios that are really justified where it makes sense. But you're right. It's often in having to build an entire center, a proton center, to deliver it. And sadly, I think it's a good example of disparities in care that you see where, unfortunately, rural patients rarely are going to have access to proton therapy. And those patients that do have access to protons either are lucky enough to live in a city with it available, or they have the resources available to them to travel or find lodging. And so it's such a challenging discussion that comes up all the time. If we see a patient from rural Colorado, do you really ask that person to, especially with the number of treatments involved, if it's weeks on end, do you ask that person to step away from their home situation, their family, and their support system, and try to go out of state to find a place where they can receive this therapy that may or may not have either theoretical or studied benefit? But it's a really hard situation.
Mm-hmm. Yeah, and I've had this conversation too where, I mean, Tim, can you estimate the cost of a proton center? Let's say we were to get one here. What do you think we would need to put down?
Millions and millions, but I don't know the exact number. In a good sense, the cost, I might be totally off on this because this is not my expertise on the proton purchasing decision, but I believe it used to be like like hundreds of millions, and now I think it's like maybe in the tens of millions range. And there's a range of kind of how many vaults do you have, how many like essentially tables do you have for a number of patients, and how complex and like how much bells and whistles do you want with the overall package. So it has improved a lot, and yet it's also something I think you see a variation of. There are academic centers that are doing it or developing them, and they're probably driving some of the clinical trials and studies. And then you may have other centers that, not to say, certainly there are really well-meaning community centers out there, but as Bill mentions, that there can be some people that look at it as a lucrative marketing option to just say we have this new technology. And admittedly, it's not that new anymore, but it is still something that's constantly developing itself and growing and expanding. And so I think it's an easy kind of marketing term to latch onto, but a very hard one to be judicious about selecting the right patients for it. And it's because it does have actual benefits that it's not just an easy yes, no for a given patient. It's something that's very individualized. We're also, I would say, even though we don't have it in the state of Colorado, we're lucky we have some surrounding centers in the surrounding states that are usually quite nice and supportive for our patients, that if they want to get those additional opinions, they often can do kind of telehealth or remote opinions, which spares the patient from having to travel out to a center and then be told, oh, you should go back home and do photon radiation, or actually you should come out here. So it's a tricky one, but I always encourage patients to seek those opinions and talk, and then really reflect on what makes the most sense for them. And I think on a separate end, I think sometimes one of the most underappreciated important factors for how somebody does with a cancer treatment is that support system, and being around family, friends, and a familiar situation. So that if somebody is considering travel for protons, it's really to talk with a radiation doctor that oversees protons and really try to understand, is this really something important where it's worth that trade-off?
Yeah, and I think one of the challenges with these types of new treatments is the incremental benefit that you might see, you may not, but you might see in the average tumor. Is it worth the squeeze? It's institutions get this, but I don't know what your clinics are like. Mine's are often overbooked. Like, we don't need necessarily at a lot of academic centers, like, we're not trying to drum a business. We want to do what's best for the patient. And those centers are built, and like that money comes from somewhere, and it's usually billed to the patient, right? Like, you have to bill them for the services provided. So it's like, can you do it? Maybe, but is the juice worth the squeeze? Is a tough call to make. And then you need people who are skilled, know how to run it.
Yeah.
So it's not like you build the thing, which, by the way, usually these require a new facility, right? Like, you have to have space.
Yeah.
You're building it from scratch. You're not just putting in a table into your existing infrastructure.
Exactly right. Yeah. And so I think it will be a technology that remains important, and we find specific indications and roles that are strongly justified. And then I think there will be other scenarios where we say it's an option, but not clearly worth, say, moving out of state or travel for a given patient. But ultimately, that's why we still have to do clinical trials and randomized trials to really try to account for biases such as those resources that some patients have and some patients don't. But it's very difficult, and it's something I've not been in that position of having cancer and trying to decide what is the best therapy for myself. But we see it every day, and it's so challenging to, even knowing what we know from our side of the expertise, it's very challenging to know what makes sense for one patient may not make sense for another patient in the exact same situation. So we all have our individual values, we all have our individual networks and support and our resources, and it's incredibly hard. So I think it's nice in this digital age that we're lucky enough we can just say, well, go talk to our colleagues that do protons. And we have a pretty small field where we often have relationships with each other and know each other in the field, that it's nice to be able to just say, I don't want my own personal bias to steer you too far away from this technology. Rather, just go talk to somebody we work with and get their opinion, and then ultimately make the best decision for yourself. And I suppose that's one of the biggest things we do in oncology is we're trying at the end of the day to help inform our patients. And personally, I don't like to tell patients you are going to do this or you need to do this. It's rather, this is what we recommend and this is what it looks like. And I want to help you as the patient decide what's best for yourself.
Along those lines, Bill, are there any new advancements that you've been hearing about that people are excited about in the radiatosphere?
Mainly the radiopharmaceuticals.
Yeah.
I feel that there are, especially after Lutathera came to market, I feel that there's a lot more radiopharmaceuticals coming to the market, and it's opening the just the amount of different cancers that it could tie to. The repurposing of a lot of these drugs is basically changing how cancer is being treated. At the same time, more of a targeted approach where the initial before it was just chemotherapy and just wipe everything out. But now we're taking a smarter approach where we're making sure that we do not destroy everything in its path, and we're only effectively going after specific tumors that have receptors and everything.
Yeah, I think that's a great point. And it also, you made this point earlier, but also another advantage of them is they can kind of be this hybrid therapy, but also diagnostic tool for us to look for and assess a cancer in a kind of smart, functional way, rather than just a traditional scan that looks at anatomy.
Mm-hmm.
Yeah, I think these things are so interesting. And as you were mentioning earlier, they emit a short wavelength of energy, so you're not getting a lot of damage to surrounding tissues. And in my mind, this is one area where I think we're a little overregulated, because you have to be specific center. Like, not everyone can prescribe these. I don't think I can. So I would love to see if it's, once we have a little more safety information about these therapies, and are they really so harmful that we need to limit them to certain centers or areas of credibility and backgrounds. Can we soon just treat them like a regular, like anything else we would give? But then again, that's my bias as being the person who's the arbiter of what goes through the veins. So, but yeah, there's regulations behind where these can be administered for sure.
Yeah, I think it's something that there are still some general principles of radiation safety, and it is admittedly something that can come through different specialists, like we said, of radiation oncology or nuclear medicine. But that I believe we're only going to see this kind of exponential growth of the range of options that we have, and yet at the same time, it's some major principles are understanding the radioactive principles of the molecule, and then also understanding the specificity or lack of specificity of the molecule that's going to seek out and find the receptors on the cancer or the target. And so understanding what other organs will take up or be exposed to this therapy in a given patient, and helping learn to manage that.
Sure. And we're wrapping up here, but Tim, if you could give a patient who's about to receive their first course of radiation advice, what would you tell them?
I'd love to hear Bill's thought too on this one, but I'll answer it. I would say, and I probably say this to most every patient I see, which is that if you can be active and find what activity you can do, it doesn't have to be running a marathon every week, but if you can get some walking in, some cardio, some weights, doing some type of activity physically as you go through treatment can be one of the best tools, both to tolerate the tiredness, but also I think to help with the overall recovery and experience. And similarly, I also think that applies to cognitive and I think emotional wellness too, is engaging yourself on all fronts, because you can control a number of things in going through cancer, but there's a lot you can't. But what you can control is what you do with your time, what you do with your activity levels. And that's not to say if you have a bad day and you feel exhausted to beat yourself up for not going for a walk, but to try to take charge of what you can actually control, and also to seek help and support when you're struggling, whether it's on a physical rehab side or an emotional wellness side with whatever you're going through. But it's sometimes the simple stuff that's the hard stuff, but I really do think we see our patients do quite well. And we're also admittedly somewhat lucky here in Colorado that we have a relatively active population, but that I often see our patients that do the best are the ones that try to take care of all domains of health as they go through this, despite the challenges.
Thank you. And as Tim alluded, next up, Bill, if you could give a new patient who's coming in and getting radiation for the first time a piece of advice, what would you relay to them?
I would totally agree with what Tim said. On top of that is don't assume. Just come into the appointment curious and ask your questions, just because assumptions is basically what causes a lot of the anxieties in the patient base. But being able to have a good relationship with whoever your clinician is and being able to get the correct answers can really just alleviate the anxieties, the stress, but at the same time give you the correct answers. Because I feel that there's too much misinformation out there and assumptions. So being able to, you don't have to have all the questions at hand before going to your visit, but just have a couple and then just build off from there. Just because I had a couple questions for this podcast, and then I just had additional questions as we were having our conversation.
Yeah, Bill, that's such a great point. And just to add to that, I will say I think one of the biggest privileges of what we do in our field is that we have more time than most specialists and most generalists to spend with our patients. Sometimes we spend an hour or more with new patients, and so we're very lucky that we also usually know their history pretty well, and they've had a number of tests and they have a diagnosis. So it's an ideal time to really focus on helping somebody understand the therapy itself and what side effects can come up. And I think getting back to my role as an educator, that's one of my favorite things with this specialty, is that every day we get this opportunity to help educate our patients and help them understand something that's rather abstract and kind of scary if you haven't been through it yourself, even if you have been through it. And so it really is a privilege to get to answer those questions.
Mm-hmm. And then just to add to that, I always tell people that us as patients, we are accountable for both our physical and mental health. We know that the side effects are coming, but what you're responsible to mitigate all those side effects in terms of being active, basically making sure you're getting enough water, and just having good relationships and moving. That's it. There's a lot of things that you can't control, but as Tim said, there are many things that you can control with your time.
All right. Couldn't have said it better myself. Bill, Tim, thank you both so much for coming on. And I think we've done hopefully a pretty good job for folks answering questions about where radiation is, what one can expect. But as always, if more questions come up, you can submit them to crackingcancer.org, and we'll have a follow-up episode if we can, and maybe pull you both back or whatever we need to do to get those questions answered. All right. Thank you both, and thank you all for listening.
Thanks.
Thank you.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research, because together we can crack cancer.